These are both areas of rapid development, and I hope you'll be able to draw out some important points that you can apply to your daily practice. So the overview for the lecture is as follows. So we'll start by talking about the role for lymphadenectomy and pancreatic cancer, specifically adenocarcinoma, and how the adequacy of lymphadenectomy has been defined in other types of gastrointestinal epithelial cancers, and how we might then apply it to pancreatic cancer through the use of the American College of Surgeons National Cancer Database. Then we'll kind of shift gears a little bit and talk about melanoma. And really there's been an explosion of chemotherapy options that I think it's important for surgeons to understand because you will be seeing patients in late stages of disease. And as surgeons, we need to understand what options are out there, what are side effects of some of these chemotherapies, and how it impacts the indications to operate and the timing of the operations. We'll talk a little bit about the role for surgical lymphatic staging in melanoma and potentially new ways for estimating melanoma prognosis. So, like I said, we'll start with some talk about pancreatic cancer. We'll just go over why lymphadenectomy has a role in the surgical armamentarium. It's really to provide prognostic information as well as a way to obtain regional control. The regional control issue is more a historic point when we were in an era where chemotherapy and radiation therapy just were not very effective for gastrointestinal tumors as a whole. I would say that pancreatic cancer, that those types of therapies still lag behind their efficacy when you compare it to other types of cancers. But overall, I'd say that the greatest benefit for surgical staging of the lymph nodes is to provide prognostic information. In other words, lymph node positive patients are going to do much worse than patients with negative lymph nodes. So how do we get to these statements about the fact that we need a certain number of lymph nodes to really determine that a patient has negative lymph nodes? And we'll go over a little bit of the primary data that has led to what now seems like a historical point. And finally, we'll explore how lymph node retrieval may be a way to kind of think about a more global aspect of cancer care, that it's not just about the lymph nodes. There may be some other factors which may play a role in why patients might benefit from a good lymphadenectomy. So, like I said, we have these magic numbers in the air that say that we need a certain number of lymph nodes to be collected and evaluated and reported during an operation to say that we've done a good job. In fact, some payers have linked this to payment, that unless you get a certain number of lymph nodes as a whole over a given period of time as an institution, you may have funds withheld, or you may not be eligible for bonuses, so to speak. And this is true for esophageal, gastric, and colorectal cancers. It was first described for colorectal cancer, where 12 is sort of the magic number. And on this chart, I've kind of detailed how these have kind of gotten started. So for esophageal cancer, this was retrospective data based on a collaborative group. For gastric cancer, this is retrospective data. You have also other multi-institutional database type projects. And then there's SEER data. What you'll notice is that none of these really have primary, the lymph node retrieval was never a primary endpoint to any randomized controlled trial. The closest you do get to it is in colorectal, where there was a subgroup analysis of a randomized controlled trial testing adjuvant therapy for node positive patients, I should say stage 2 and stage 3 patients. But somehow, despite not having really good level 1 evidence for this, this has really come to the top and is recognized and pushed by the National Comprehensive Cancer Network, which is generally one of the most highly regarded cancer algorithms and treatment strategy plans for patients with cancer. So let's kind of take a trip back down memory lane here and really reevaluate how this lymph node minimum got started specifically for colorectal cancer. And looking back through the literature, really the earliest mention of this that I could find dates back to 1990, where there was a global consensus that really sat down and tried to answer the question, okay, we have 6 different cancer staging systems that we can choose from at the time, and we need really a way to unify things. So they kind of got together half-heartedly with the goal of, well, maybe we should just make our own staging system, and this will be the staging system to end all staging systems for colorectal cancer. Well, that's not really what they ended up doing. They ended up saying, we don't really need another staging system, we just need a way to integrate the most important points in a way that's consistently reportable and clearly reported, and everybody just needs to agree that these are the salient points of how we report cancer operations. And so instead, they came up with what today we would probably call as the synoptic report. So a very categorized way of reporting in a pathology report of how many lymph nodes were retrieved, how deep the tumor is, the amount of chemotherapy effect that's seen histologically, things like that. And part of this synoptic report and part of their recommendations were that a good lymphadenectomy should consist of 12 lymph nodes. And again, this was a consensus group. There was no data that was used to justify why 12 lymph nodes was selected, but that was just the consensus among experts, and that began to be highly quoted among other literature, and people looked for ways to sort of validate that. And so one of those validations actually comes from our very own institution. Dr. Bland was the senior author on this paper dating back from 2003 in the Annals of Surgical Oncology, where looking at the National Cancer Database, specifically for colorectal cancer, in T3N0 cancer, there were survival differences seen based on the number of lymph nodes that were resected and evaluated during an elective colorectal operation. And here we can see clear curve separation, again, kind of favoring this transition of 12 to 13 lymph nodes as being significant for having defined a truly negative lymphadenectomy. I mentioned to you that there was data from the colorectal data set that was actually prospective, even though it wasn't the primary endpoint for this study. This is randomized controlled data from an adjuvant trial that accrued patients with stage 2 and stage 3 resected colorectal cancer, and did a multivariable analysis looking for overall survival as well as a number of other survival data points. And the number of lymph nodes recovered, not the number of positive lymph nodes, not the presence of positive or negative lymph nodes, but the number of lymph nodes evaluated, was a highly significant predictor of overall survival in both the node negative patients and the node positive patients. So this is probably the highest level data that you can come across that you could use to defend why the number of lymph nodes should be, there should be a minimum to define what an adequate lymphadenectomy is. And what we're really talking about is a staging effect. In other words, if I do a colorectal operation and I take out 5 lymph nodes, how do I know that that 6th lymph node, which still resides in the patient's abdomen, maybe that was the one metastatic lymph node, and maybe now I have inappropriately called this patient node negative when they should really be node positive, and they will behave like a node positive patient. And so that's this idea of stage migration. If you resect too few negative nodes, then the next node might have been the positive one that would have changed your true stage. Like I talked about, there is an element of local control, although this is very hard to prove, and nobody has really demonstrated it in a convincing manner that resecting more positive nodes debulks the overall tumor burden and somehow impacts survival. The medical oncologists probably place more of an emphasis on this. From a surgical standpoint, we do place some emphasis on it, because if we say that there is a lymph node beyond the anatomic basin that would be included in our standard elective operation, then in many situations we'll consider that metastatic disease and will not operate on that patient. And then the last point is that nodes can be a surrogate for compliance with other surgical quality measures. So for instance, maybe this is just a measure of how well we're taking care of a patient overall. It's not, maybe it doesn't matter how many lymph nodes you get out, but if you take out enough lymph nodes, maybe then you're following this patient better in the postoperative care. Maybe you're doing a better job of getting them chemotherapy when they need it. Maybe you're doing a better job of getting radiation therapy when you need it. Maybe you're doing a better job of getting that colonoscopy a year after their operation. And so maybe this is just one of many parameters that describes the quality of overall care that you're providing for that cancer patient. So, having explored a little bit where these recommendations came from for colorectal cancer, let's try to apply them to pancreatic cancer. So this is the published literature talking about the extent of lymphadenectomy for patients with pancreatic adenocarcinoma. And you'll see there's really no prospective randomized data or even a subset analysis of a randomized trial that was conducted for a different purpose. The number of lymph nodes that are recommended in these prior papers ranges between 11 and 15. These papers really only looked at long-term survival as their only outcome for determining what an adequate versus inadequate lymphadenectomy was. And so the purpose of my project was to look at how lymph node retrieval impacts not only overall survival, but how it might also co-migrate with some of these other quality measures that we've talked about, more short-term outcomes rather than just survival. And we'll go over what exactly those short-term outcomes might be. So again, the purpose of this study is to investigate the relationship of short and long-term outcomes of pancreaticoduodenectomy, so a Whipple operation, with respect to the number of lymph nodes examined in the surgical specimen. And again, it's important to realize that this is not just on the surgeon. This is a working relationship between how many lymph nodes the surgeon removes and how many lymph nodes the pathologist reports. So it's a two-way street. I chose to use the National Cancer Database, which is a service provided by the American College of Surgeons. The data that I used ranged from 1998 through 2011, and I should thank Dr. Bland for helping me acquire this data. It includes data from over 1,200 Commission on Cancer facilities within the United States, and I selected only those patients who had pancreatic adenocarcinoma who underwent pancreaticoduodenectomy. So I'm eliminating neuroendocrine tumors, benign pancreatic cysts. I'm eliminating patients who underwent distal pancreatectomy, enucleations, total pancreatectomies, things like that. And I wanted to focus on patients who had a reasonable outcome. So I exclude the patients who had less than 90 days of follow-up due to poor follow-up or due to inpatient death. And I wanted to exclude the patients, again, with unknown pathologic margin status, because this is really looking at surgical quality, and that's another major source of quality. So these are the demographic characteristics and some of the clinical characteristics of the patients. So there were 26,792 patients. Obviously, this is a big data set, which is nice for looking at some of these outcomes. It's equal, well, you have your expected distribution of TNM stages. There is a similar size with respect to the primary tumor in the node negative versus the node positive patients. This was really before the era of neoadjuvant chemotherapy and radiation therapy, so it's not surprising that those numbers are small. And the NCDB does allow you to sort of parse data whether this was an academic center by their standards or a non-academic center by their standards. This delves into a little bit more detail about those clinical parameters. So this is the distribution of lymph nodes that were examined in the lymph node positive and the lymph node negative group. We're going to explore this in a little bit detail in graphical format on the next slide. But here's the margin status, and this is consistent. The nodal status is about 60% positive, and that's consistent with other large trials that have been conducted in the past. And this is a challenging operation, so almost 25% of patients, despite having an operation with curative intent, will still have positive surgical margins. And it's a difficult recovery with about a 10% 30-day readmission rate and a hospital stay of about 11 days. So again, in graphical format, here's the frequency of lymph nodes that are examined with a median of 11. And so you can see about the 50% dividing line is this 10 to 11 lymph node retrieval mark. In this data set, about 79% of patients had a standard antrectomy as part of their Whipple operation. Pylorus preserving was less frequently utilized, about 12% of the time. And looking at the lymph node retrieval, there was no difference in lymph node retrieval when you sorted by what kind of operation they had. If you look at the node-negative patients, overall they had fewer lymph nodes retrieved than patients with lymph node positive. So again, you have this concept that starts to creep in. The harder you look, the more you'll find. So again, the lymph node negative patients had fewer lymph nodes that were evaluated compared to the lymph node positive patients. And this was a very statistically significant finding. One thing that you'll find with this database and any other large database, very small numerical differences will show up as being statistically significant because it's an overpowered data set. And so one of the limitations that we'll talk about later is the fact that even though a lot of this is statistically significant, as surgeons and as clinicians, we have to figure out what is actually clinically relevant, not just what's statistically significant. Again, looking at the impact of length of stay on lymph node retrieval, if we only restrict this to the lymph node negative patients, if you have 1 to 9 lymph nodes examined, you have a higher length of stay than patients with greater than 10 lymph nodes examined. And not only is this significant, but you can start to see how about 2 hospital days is potentially clinically relevant, both from a recovery standpoint and from an economic standpoint for a hospital as well. This is well known. This is not new data that node positive patients have a worse survival compared to the node negative patients. This is sort of an internal control. Does this data set hold up with other published data? And yes, it absolutely does. There's a clear separation in survival curves, as you can see here. So next, the idea was to look at multivariable predictors. So how does the interaction with many different parameters impact the statistical significance of lymph node retrieval? And here you can see that if you take all patients, that the number of lymph nodes examined is again a multivariable predictor of whether or not you're going to pull out a positive lymph node. Again, the harder you look, the more you're going to find. Now, this is a multivariable predictive model looking at how likely you are to achieve a negative surgical margin. Again, you see the number of lymph nodes examined is statistically significant when you look at all patients and when you restrict that to the node negative patient subset. Another multivariable model looking at the duration of length of stay. I showed that to you in the univariable model, and this is the multivariable model. Again, so the more lymph nodes that you remove, the shorter your length of stay, which kind of almost goes a little contrary to what you think. I'm doing a more aggressive operation, I'm taking out more lymph nodes, maybe my recovery is going to be longer. Not so. This is also true in the node negative patient subset. This is another multivariable model looking now at 30-day hospital readmission. And again, the number of lymph nodes examined is a predictor of less likelihood to be readmitted within 30 days. This is also true in the node negative patient subset. And the same is true for mortality. Nodes examined in all patients and in the node negative patient subset. So now let's kind of tease out a little bit more of that stage migration, and let's use these Kaplan-Meier survival curves to do that. So this is just a little bit of thought experiment. So I'm only going to involve node negative patients here. And basically we want to see a Kaplan-Meier curve separation. So I showed you those curves where the lymph node negative patients live longer than the lymph node positive patients. So let's try to superimpose a number of those different curves using different thresholds as of my lymphadenectomy. And what you want to do is you want to see curve separation, and you want to see the optimal curve separation. So you want to see those curves get as far apart as possible and then sort of plateau. And multiple colorectal cancer papers have done this looking at stage 2 and stage 3 patients. So let's try to do this first thought experiment with pancreatic cancer. So this is my hypothetical survival curve versus lymph nodes resected for lymph node negative patients here. And so this is a ridiculous lymph node threshold for one lymph node. I mean, this is the very minimum. If you can't get one lymph node out, you might as well maybe pick a different career. And so obviously, the proportion of patients where you can get one lymph node out is going to be at least 90%. But you're really, based on this criteria, you're really not doing a good job at separating these two patient populations, so you really have no curve separation in your Kaplan-Meiers. Okay, so let's go up to 3 nodes. How does this change the survival curves? Now, you have more patients that fall off because they have an inadequate lymphadenectomy. Here you're starting to get a little bit better curve separation. These patients with 3 lymph nodes are living longer, mostly because you've gotten rid of the bad actors and put them back down into that blue line. Let's go a little bit more. 6 lymph nodes. Again, now you're culling out up to 25% of those patients. All those bad actors are down here in this blue line, and now you have excellent curve separation. Let's push it 1 notch further and see what happens. Here we have no additional survival improvement because the good patients are up in the red curve and the bad patients are down in the blue curve. But what you're doing now is you are super selecting patients, and now you only have 20% of patients which are meeting your benchmark. And if we're going to define a minimum number of lymph nodes, we want this to be an attainable goal, because this is a global goal that we're going to ask all hospitals to achieve, all surgeons to achieve, not just at our hospital, but across the country. And if only 20% of surgeons and hospitals are able to achieve that, then that's not a reliable and a realistic goal, and people are just not going to pay attention to it. So let's apply this same thought process to the National Cancer Database data. So here we have, and these are true survival curves with these different lymph node thresholds. So here you have greater than 5 or 1 to 4, and you see some curve separation there, but they get pretty close here. These are all statistically significant again, so you have to keep in mind what's clinically relevant. Now if you bump that threshold up to 8 lymph nodes, still you have some curve separation, not great. Let's go up to 10, 15, 12, you're getting some more curve separation, and now up to 15. So somewhere in here there's a happy medium where you're getting good stage migration, so you have adequate staging, and you still have an achievable goal in terms of what you can achieve during your operation and what the pathologist can achieve during their evaluation. Now, like I mentioned, all of those curves are statistically significant, so how are you going to make this decision? How do you choose? Well, one of the other papers that is probably the most often quoted paper looking at lymphadenectomy for pancreatic cancer is shown down here, and they did something really neat. So they looked at the log ranks test statistic, not just the p-value, because the p-value is significant for all of these different lymph node thresholds. And if you look at the log rank statistic, you do see how there's sort of a peak. 84, 83, 85, and then things start to dip again. So maybe this threshold of 10 might be our optimal lymph node retrieval for pancreatic cancer. So overall, in this data set, what is the compliance with that 10 lymph node threshold? About 40% of patients did not meet that minimum threshold of 10 lymph nodes retrieved. So we're getting closer to being able to define something that might be a reasonable minimum number of lymph nodes during lymphadenectomy for pancreatic cancer. Now, this is really kind of drives it home. What I'm not trying to do is define a specific number of lymph nodes, because when you plot the number of lymph nodes that you have examined in node-negative patients and you compare that to median survival, you have basically a linear curve. Again, the harder you work, the better outcome you're going to get, the more lymph nodes you're going to get out. What you don't see on this curve is you don't see a particular inflection point. An inflection point would say, if I get this many lymph nodes, I've maximized my survival, and if I get more than that, I'm actually hurting the patient because maybe they're staying in the hospital longer, maybe they have more complications, things like that. So you don't see that sort of inflection point. So this is a linear function, and maybe there isn't a particular magic number. And so maybe this is purely just policy, how we're implementing cancer care across the country. So the limitations to this data, like I mentioned, this is retrospective data. Not all the NCDB fields are 100% complete. It relies on data abstractors in individual hospitals. There were a small number of stage 4 patients included in this data set. This is an overpowered data set is the main limitation to this study for the reasons I've already detailed, how these things are statistically significant but may not always be clinically relevant, and that's where we have to apply our thinking as clinicians. But in conclusion, I think you can say from this data that the increased lymph node retrieval is a multivariable predictor of retrieving a positive lymph node, obtaining a negative surgical margin, decreased length of stay, decreased length of risk of 30-day postoperative hospital readmission, and overall survival. And at the same time, the relationship between the lymph node retrieval and survival is nearly linear, and there's no clear inflection point that should signal a clinically relevant threshold to say, yes, you've done a good job, or no, you haven't done a good job.